Welcome to the deep dive. Today, we are immersing ourselves in one of the most intricately designed systems in human anatomy, the female reproductive system.
Absolutely. It's just incredibly complex.
And we're not just aiming for simple knowledge here. We're going deep. We want true professional mastery of the functional genius of this system. That includes the layered support structure, the stuff that literally holds life, and the internal organs together.
That's exactly right. And to do that, our source material is drawn from some really extensive, detailed excerpts. We're talking about a comprehensive textbook of obstetrics.
Okay.
So this level of detail, we're looking at structure, relations, blood supply, nerve pathways, even the embryological homologies. This is really the roadmap to achieving that kind of mastery you're talking about.
Okay, let's unpack this then. Our mission for this deep dive is to move way beyond just simple definitions. We want to master the layered, interconnected anatomy of the entire female pelvis. We'll be moving systematically. So starting with the external components, the external genitalia, then moving inward to the sort of visceral core, the vagina and uterus, before spending some really crucial time analyzing that foundational support framework, the pelvic floor and fascia.
Critical stuff.
And finally, we'll connect all this to the associated urinary organs and those accessory reproductive organs, the breasts.
Think of it as a structured journey, really. If you want professional competency here, you have to appreciate the three-dimensional relationships.
Yeah.
Especially those critical anatomical crossings we'll cover. Understanding why a structure is placed where it is, and importantly, what its vulnerabilities are. Well, that's the difference between just general knowledge and genuine elite insight.
Perfect. Let's start that journey. Okay, we begin at the exterior then. The vulva, or sometimes called the pudendum. This anatomical region basically encompasses all the visible external genital organs, and they're situated within the perineum.
And to map this out precisely, you need the boundaries. So anteriorly, it's bounded by the mons pubis.
Yeah.
Posteriorly by the rectum, and then laterally by what's called the genitocrural fold, basically the thigh crease.
Okay.
The entire surface here is covered by keratinized, stratified squamous epithelium, which is just, tough protective skin designed for exposure.
Right, makes sense. So kicking off the specific structures is the mons veneris, or mons pubis. This is that anterior pad of subcutaneous adipose connective tissue. Essentially, it's a fatty cushion right in front of the pubis bone.
And after puberty, obviously, it's covered by hair. This typically forms a triangular pattern. The technical term is escutcheon, with the base pointing upwards.
Got it. Now, moving laterally from the mons, we encounter the labia majora.
Yes, these are the prominent sort of longitudinal elevations of skin and subcutaneous tissue. They form the lateral boundaries of the vulva.
And they meet up, right?
They do. Medially, they converge posteriorly to form the posterior commissure, which sits just in front of the anus.
Looking closer at their structure, the outer surface, the convex part, is pigmented and hairy, like the mons.
But if you look at the inner surface, it's quite different. It's thinner, and it has sebaceous glands. But, and this is key, no hair follicles there.
Ah, okay.
The tissue inside is a mix of dense connective tissue and a significant amount of adipose tissue fat.
Now, you mentioned homologies earlier. This is a big one, isn't it?
It is. This is where it gets really interesting for comparative anatomy. Structurally, developmentally, the labia majora are homologous to the scrotum in the male.
Wow, okay.
And clinically, this is critical. They are packed with this extensive venous plexus right beneath the skin.
Meaning?
Meaning if this area gets injured, especially under the high pressure of childbirth, they're highly prone to forming hematomas, large collections of blood, very quickly and severely.
That's a major risk then.
Absolutely. Also, a little anatomical detail to file away. The round ligament, which is one of the supporting structures coming from the uterus, actually terminates right at the upper border of the labia majora.
Okay, interesting connection. Now, if we were to sort of peel back the majora, we'd find the labia minora underneath.
Exactly, two thin folds of skin. And what's notable here is they are completely devoid of fat.
No fat at all.
No fat. They contain connective tissues, lots of sebaceous glands, some erectile muscle fibers, vessels, and nerve endings. But specifically, no hair follicles and no sweat glands.
And their attachments are a bit complex.
They are. Anteriorly, they actually split into two little folds, or lamellae, to enclose the clitoris. The fold in front forms the prepuce, or hood, and the fold behind it forms the frenulum.
Okay.
Then, posteriorly, they typically fuse across the midline. This fusion forms the fourchette.
Ah, Yeah, the fourchette. That sounds familiar from an obstetric context.
It should. It's a delicate fold, and it's very often lacerated during childbirth. It's an important landmark.
In the space behind it.
The space located between that fourchette and the actual vaginal orifice is called the fossa navicularis.
Got it.
And just to bring it back to homology mastering, this means understanding that the labia minora are homologous to the penile urethra and also part of the skin of the penis in males. Again, showing those shared embryological origins.
Fascinating. Okay, speaking of homology, let's discuss the clitoris. It's described as a small cylindrical erectile body, maybe 1.5 to 2 centimeters long, located right at the front, most anteriorly.
That's right. Structurally, it consists of a glans, the visible tip of body, and then 2 internal crura, or legs, that attach to the pubid bones. Internally, it's composed of 2 cylindrical corpora cavernosa, that's the erectile tissue itself.
And the glans?
The glans is covered by squamous epithelium, like the surrounding skin, but it's extremely richly innervated, makes it intensely sensitive.
Now, the homology here is to the penis, obviously.
Correct.
But there's a critical difference.
A crucial difference. It is entirely separate from the urethra. Unlike the male penis, which serves both reproductive and urinary functions, the clitoris's separation from the urethra means its function is purely sensory. That's a key distinction.
Okay, that makes sense. So that brings us to this space enclosed by all these structures. The vestibule.
Yes, the vestibule. It's that triangular space bounded by the clitoris up front, anteriorly, the fourchette behind, posteriorly, and the labia minora on the sides, laterally.
And this space is important because of what opens into it, right? 4 key openings.
Exactly. It's defined by those 4 openings. You have to know them.
Okay, let's map them out. First, the urethral opening. Where is that exactly?
It's right in the midline, about 1 to 1.5 centimeters below the pubic arch, and you'll find the smaller periurethral ducts opening nearby too.
Okay, 1 down. Second opening.
Second is the vaginal orifice and the hymen. The hymen itself is a septum, a fold of mucous membrane, and its size and shape vary enormously between individuals.
And after childbirth?
Right, for our professional audience, knowing the post-childbirth appearance is key. The remnants of a hymen that's been significantly torn, usually during delivery, are represented by these small, scarred nodules. They're called the carunculae myrtiformes. Seeing those tells you something important about the patient's obstetric history. It's basically scar tissue.
Good clinical pearl. Okay, third set of openings.
These belong to the Bartholin's ducts. They lead from the Bartholin's glands, also called the greater vestibular glands. These are paired, about pea-sized, located down in the superficial perineal pouch.
And their function, not minor, right?
Not minor at all. Functionally vital. They secrete this abundant alkaline mucus, especially during sexual excitement. This is the primary source of lubrication for intercourse.
Where exactly do the ducts open?
The duct itself is about 2 centimeters long, and it opens very specifically. Just outside the hymen, right at the junction of the anterior 2/3 and the posterior 1/3 of that little groove between the hymen and the labia minus.
Precise. And the homology?
Homology alert again. Bartholin's glands are homologous to the bulbourethral glands, Cowper's glands, in the male, which also contribute to pre-ejaculate fluid. Oh, wait, sorry. The source says homologous to the bulb of the penis. Let's stick to that.
Okay, bulb of the penis. Got it. And the fourth opening?
The fourth are the openings for Skene's glands, also known as the periurethral glands. Skene's glands are actually the largest of these periurethral glands. Their ducts open very close to the external urethral meatus, the opening of the urethra.
And another homology here.
Yes, another really high-impact one. Skene's glands are homologous to the prostate in the male.
The prostate, wow.
Yep, and just like the prostate, they can be susceptible to infection, sometimes chronic inflammation, and even potential adenoma formation, though that's less common than prostatic issues.
Okay, that's a really important connection to make. We also need to mention the vestibular bulb, right?
We absolutely do. These are bilateral, one on each side, masses of erectile tissue. They lie just beneath the mucous membrane of the vestibule, and they're sort of incorporated with the bulbocavernosus muscle, which covers them.
Homologous to?
Homologous to the bulb of the penis and the corpus spongiosum in the male erectile tissue.
And clinically?
Clinically, just like the labia majora, they are highly vascular, very susceptible to brisk hemorrhage if they get injured during childbirth. Another potential source of significant bleeding.
Okay, that covers the structures. Let's quickly master the blood supply, drainage, and nerves critical for things like regional anesthesia.
Absolutely. The arterial supply is robust. It comes mainly from branches of the internal pudendal artery. Think labial branches, transverse perineal, clitoral artery, artery to the vestibular bulb.
But not just that.
No, it also gets contributions from the femoral artery via its superficial and deep external pudendal branches. The fact that you have blood supply coming from both major pelvic sources, the internal iliac via the pudendal and the femoral artery, means there's excellent collateral circulation. Good redundancy.
Yes. But it also means if you have significant trauma, you've got a complex network to potentially control bleeding from.
Right. What about venous drainage?
It involves these extensive plexuses. They drain primarily into the internal pudendal vein, but also connect into the vesical bladder, or vaginal venous plexus, and importantly, into the long saphenous vein in the leg.
Ah, the saphenous vein connection.
Exactly. That convergence explains why varicosities, varicose veins of the vulva, are relatively common during pregnancy. And these varicosities carry a real risk of spontaneous rupture. That's a key clinical detail for pregnant patients.
Definitely. Okay, nerve supply. This is essential knowledge for doing nerve blocks, like a pudendal block.
Totally essential. The innervation relies on bilateral spinal somatic nerves. It's quite specific. The anterosuperior part, sort of the upper front area, is supplied by spinal levels L1 and L2 via the ilioinguinal nerve and the genitofemoral nerve.
L1, L2.
Okay. The postero-inferior part, back and lower area, is supplied by S1, S2, and S3. These come via pudendal branches from the posterior cutaneous nerve of the thigh. S1, 2, 3 from the thigh nerve. Got it.
And then the middle vulva, the main central part, gets its supply from S2, S3, and S4 via the labial and perineal branches of the main pudendal nerve.
S2, 3, 4 via the pudendal.
Precisely. Understanding these specific spinal segments and nerve distributions is absolutely essential if you're going to accurately target, say, a pudendal nerve block for pain relief during delivery.
Makes sense. Lastly, for the externals, lymphatic drainage. Vital for cancer staging.
Absolutely vital, and it's bilateral. Lymphatics flow primarily to the superficial inguinal nodes, those nodes you can feel in the groin.
Okay.
From there, some go to the intermediate groups of inguinal lymph nodes, including a specific node called the gland of Cloquet, which sits near the femoral canal. And eventually, drainage can reach the external and internal iliac lymph nodes deeper in the pelvis.
So a stepwise drainage pattern, mostly towards the inguinal nodes first.
Primarily, yes. That superficial drainage is key.
And just to wrap up the external section, a quick synthesis on the developmental origins. You mentioned homology. Where did these parts come from?
Right, quick summary. The clitoris develops from the embryonic genital tubercle. The labia minora developed from the genital folds. The labia majora developed from the larger labioscrotal swellings. And the vestibule, that central space, derives from the urogenital sinus.
Incredible how those basic embryonic structures differentiate so distinctly. That detailed tour of the external anatomy really sets us up perfectly for moving inside.
Exactly. So moving deeper now, we enter the internal genitalia. These obviously require specialized instruments for inspection and any kind of manipulation. We'll start with the vagina.
Right, the vagina. Described as a fibromusculo-membranous sheath connecting the cervix, the neck of the womb, down to the vulva we just discussed. Hashtag 2.1 vagina.
And its function is really threefold. First, it's the excretory channel for normal secretions and, importantly, for menstrual blood.
Okay.
Second is the organ of copulation. And third, during parturition or childbirth, it forms the incredibly flexible and distensible lower part of the birth canal.
Its position in the pelvis is quite specific, isn't it? It's not just straight up and down.
Not at all. Its position is essential for supporting the organs above it, like the uterus and bladder. It's directed upwards and backwards. If you imagine someone standing erect, the vagina forms an angle of about 45 degrees with the horizontal.
45 degrees up and back. Okay.
And crucially, its long axis runs nearly parallel to the plane of the pelvic inlet, the top opening of the bony pelvis. And, importantly, it lies approximately at right angles to the normal axis of the uterus, which typically tilts forward over the bladder.
That right angle relationship seems important for support.
It is. Now, the dimensions are interesting. They're not uniform. The anterior wall, the front wall, is shorter, about 7 centimeters long.
Only 7 centimeters.
Rightfully.
Yeah.
While the posterior wall, the back wall, is significantly longer, measuring about 9 centimeters.
Huh. Why the difference?
It's mainly due to the way the cervix projects into the top of the vagina. It pushes the posterior wall back further.
Okay. And you mentioned it looks H-shaped in cross-section?
Yeah, on a transverse section, it often has an H shape. This is because the anterior and posterior walls are usually collapsed against each other, while the lateral side walls are a bit stiffer and held open by their connections to the pelvic floor muscles.
But despite this resting shape, it's incredibly distensible.
Amazingly so. Its elasticity is crucial for accommodating intercourse and, of course, the passage of a baby during labor.
You mentioned the cervix projecting into the vagina. This creates folds, right? The fornices.
Exactly. The cervix dips down into the vaginal vault, creating these gutters or clefts all around it. These are the fornices. There are 4 of them.
4.
Yep. One anterior fornix in front of the cervix is the most shallow one. One posterior fornix behind the cervix, this is the deepest one. And then 2 lateral fornices, one on each side.
And the depth of that posterior fornix is significant.
Very significant clinically. Because it's the deepest, it lies directly against the peritoneum of the pouch of Douglas, which is the lowest point of the peritoneal cavity in the female pelvis, meaning the posterior fornix is a key site for clinical access. You could potentially drain fluid collections, like blood or pus, from the pouch of Douglas through the posterior fornix. It's also a potential site for surgical entry into the pelvic cavity in some procedures.
Okay, critical landmark. Now, the surrounding relations of the vagina, what's next to it that seems paramount for surgery?
Absolutely paramount. You have to know these relations, Cole. Let's break it down. Anteriorly, so in front of the vagina, the upper 1/3 is directly related to the base of the urinary bladder. The lower 2/3 are related to the urethra.
Ah, the urethra again.
Yes, and note this detail. The lower half of the urethra isn't just near the vaginal wall. It is firmly embedded within the anterior vaginal wall tissue. They're stuck together.
Okay, firmly embedded. That's important. What about posteriorly, behind the vagina?
Posteriorly. The upper 1/3, as we said, is related to the pouch of Douglas, with likely some loops of intestine sitting in that pouch.
Right.
The middle 1/3 is separated from the anterior wall of the rectum by a layer of fascia called the rectovaginal septum.
Okay, a separating layer there.
And the lower 1/3 is separated from the anal canal by that crucial supporting structure we'll detail more later, the perineal body.
Okay, so bladder and urethra in front, pouch of Douglas, rectum and perineal body behind. What about the sides, laterally?
Laterally is where we find another vital anatomical relationship, especially involving blood vessels and the ureter.
Ah, the ureter crossing. We'll come back to that with the uterus too, right?
We will, but it's relevant here too. So laterally, the upper 1/3 of the vagina is related to the pelvic cellular tissue at the base of the broad ligament. And lying within this tissue, running close to the vagina, are the ureters, carrying urine from the kidney, and the uterine artery, supplying the uterus.
How close are they?
They are positioned approximately 2 centimeters away from the lateral fornices, the side gutters around the cervix. This proximity is critical during hysterectomy or repairs in this area.
2 centimeters. Okay. What about the middle and lower thirds laterally?
The middle 1/3 of the vaginal wall actually blends with fibers of the levator antemuscle, part of the pelvic floor. And the lower 1/3 is related to the structures in the superficial perineal pouch, the bulbocavernosus muscles, the vestibular bulbs we mentioned earlier, and Bartholin's glands.
Wow. Okay. Lots of critical neighbors. Let's talk structure of the vaginal wall itself. 4 layers.
4 layers, synthesized from the inside out. First, the mucus coat, the lining. This is stratified squamous epithelium, similar to skin but not keratinized. And notably, it has secreting glands of its own.
No glands. So where does lubrication come from?
Good question. Vaginal lubrication during arousal comes primarily from the Bartholin's glands secreting mucus near the opening, and also from transudation fluids seeping through the vaginal walls from the underlying blood vessels, not from glands within the vaginal lining itself.
Interesting. Okay, layer 2.
Layer 2 is the submucous layer. This is loose connective tissue, but it's highly vascular, containing lots of blood vessels. That's where the transudate comes from.
Makes sense. Layer 3.
Layer 3 is the muscular layer. It's often described as having an inner circular layer and an outer longitudinal layer of smooth muscle, though these layers aren't always perfectly distinct.
And the outermost layer.
The outermost layer is the fibrous coat, sometimes called the adventitia. This is derived from the endopelvic fascia, the connective tissue framework of the pelvis, and it's also highly vascular.
Okay, 4 layers. Mucosa, no glands, submucosa, vascular, muscularis, and fibrous coat. What about the functional environment inside the vagina?
Very important aspect. From puberty through to menopause, the normal vaginal environment is highly acidic. The pH is typically between 4 and 5.
Why so acidic?
It's due to the activity of beneficial bacteria, primarily Deuterlein's bacilli, a type of lactobacillus. These bacteria live on glycogen, a sugar that's present in the exfoliated, shed vaginal epithelial cells. They metabolize this glycogen and produce lactic acid as a byproduct.
Ah, lactic acid lowers the pH.
Exactly. And this acidic environment is a critical protective mechanism. It inhibits the growth of many pathogenic bacteria and fungi, helping to prevent ascending infections from reaching the uterus and tubes.
And this depends on estrogen.
Absolutely. The amount of glycogen in the vaginal cells is directly related to estrogen levels. So the acidity varies with the menstrual cycle, and it changes significantly before puberty and after menopause when estrogen levels are low. The pH becomes more neutral or alkaline then, making the vagina more susceptible to infection.
Fascinating defense mechanism. Okay, blood supply and nerves for the vagina.
The blood supply is quite rich, forming longitudinal arteries called the anterior and posterior azygos arteries that run down the midline. These are fed by multiple sources: the cervicovaginal branch of the uterine artery, the vaginal artery itself, often a direct branch of the internal iliac, the middle rectal artery, and the internal pudendal artery supplying the lower part.
Multiple sources again. Nerves.
Nerve supply comes mainly from the inferior hypogastric plexus, also called the pelvic plexus, carrying both sympathetic and parasympathetic fibers. The lower part of the vagina, however, which is more sensitive, receives somatic sensory innervation from the pudendal nerve, the same nerve that supplies the external genitalia.
Okay, pudendal nerve again for the lower part. And development. You mentioned a dual source earlier.
Yes, mastery requires noting this. The upper 4/5 of the vagina, basically everything above the level of the hymen, its mucous membrane lining, comes from the endoderm of the embryonic sinovaginal bulbs. The musculature for this upper part comes from the mesoderm associated with the Mullerian ducts, which also form the uterus and tubes.
So sinovaginal bulbs and Mullerian ducts for the top part. What about the bottom?
Only the lower 1/5, the part below the hymen, develops from the endoderm of the urogenital sinus, the same structure that gives rise to the vestibule. So two distinct embryological origins contributing to the final structure.
Very cool. All right, let's move up to the uterus. Hashtag tag 2.2 uterus.
Right, the uterus. The hollow, pear-shaped, pariform muscular organ. It's really the powerhouse of reproduction, designed for implantation, gestation, and labor.
And its normal position is quite specific, using those terms anteversion and anteflexion. Can you break those down?
Sure. Anteversion means the entire uterus is tilted forward relative to the long axis of the vagina. Remember we said the vagina goes up and back at 45 degrees? The uterus normally tips forward from the top of the vagina.
Okay, tilted forward. And anteflexion.
Anteflexion means the body of the uterus itself is bent forward relative to the cervix. So there's a forward tilt and a forward bend. The uterus normally rests sort of draped over the bladder.
But it's not always perfectly centered, is it?
No, and this is a subtle but important point. It often inclines slightly to the right side of the pelvis. This tendency is called dextrorotation.
Rotated to the right. And the consequence?
The consequence of the body rotating slightly right is that the cervix, the lower part, often gets directed slightly towards the left, a counter movement called levarotation.
Levarotation of the cervix. Why does that matter?
It matters because it brings the left side of the cervix into closer anatomical relation with the left ureter as it passes by. That subtle, natural anatomical bias has potentially huge implications during pelvic surgery near the cervix on the left side. The ureter might be closer than you expect.
Wow, okay. Need to remember that dextro-rotational levarotation tendency. What about size?
Let's nail the typical measurements for a non-pregnant adult uterus. It's about 8 centimeters long, about 5 centimeters wide at its broadest part, the fundus, and the walls are quite thick, about 1.25 centimeters thick.
And weight?
A normal non-pregnant weight typically ranges between 50 and 80 grams. Obviously, this changes dramatically during pregnancy.
Of course. Now, the parts of the uterus, it's divided into...
Primarily 3 parts: the body, or corpus, the isthmus, and the cervix.
Let's start with the body.
The body, or corpus, is the main upper expanded part. The very top rounded part above the level where the fallopian tubes enter is called the fundus.
The fundus, often measured during pregnancy.
Exactly. Fundal height is a key measure. The body proper is below the fundus. And the superlateral angles of the body, where the tubes join, are called the cornua, singular duct cornu. This is a really important anatomical point because it's the precise spot where 3 structures attach: the fallopian tube, the round ligament going anteriorly, and the ovarian ligament connecting to the ovary posteriorly, all converge at the cornu.
Okay, body includes fundus and cornua, then the isthmus.
The isthmus is the short, constricted part, only about 0.5 centimeters long, that forms the transition between the main body and the cervix below. It's a narrowing.
Where exactly is it located?
It's defined as being between the anatomical internal os, the opening from the body cavity above, and the histological internal os, a microscopic transition point in the lining, identified by Aschoff below. During pregnancy, this isthmus thins out and elongates significantly to form the lower uterine segment.
The lower segment in labor. Got it. And finally, the cervix.
The cervix, the neck of the uterus, is more cylindrical, about 2.5 centimeters long in the non-pregnant state. It extends down from the isthmus to the external os, the opening into the vagina.
It is divided further.
Yes, the part of the cervix above the vaginal attachment is the supravaginal part, and the part that protrudes into the vagina, creating the fornices, is the vaginal part, or portio vaginalis.
Okay. What about the cavity inside the uterus?
The total length of the uterine cavity from fundus to external os is typically around 6.5 to 7 centimeters. The cavity within the body is flattened anteroposteriorly and is triangular in shape when viewed from the front, about 3.5 centimeters long. The canal within the cervix, the endocervical canal, is more spindle-shaped or fusiform and about 2.5 centimeters long.
So roughly 6.57 centimeters total internal length. Got it. Now, relations, what's around the uterus, this is defined by the peritoneum, right?
Exactly. The way the peritoneum drapes over the pelvic organs defines the spaces and relations. Anteriorly, the body of the uterus is separated from the urinary bladder by that peritoneal fold we mentioned, the uterovesical pouch. Below the level of the internal onus, the supravaginal cervix is separated from the base of the bladder by just some loose areolar connective tissue. There's no peritoneum between them there.
Okay. Uterovesical pouch above, loose tissue below. Posteriorly.
Posteriorly, the entire back surface of the uterus, body and supravaginal cervix, is covered by peritoneum. This peritoneum then reflects off the uterus onto the rectum, forming the deep pouch of Douglas, or rectuterine pouch. So the posterior uterine wall forms the anterior wall of the pouch of Douglas.
And what's usually in the pouch of Douglas?
Often contains loops of small intestine, sometimes the sigmoid colon.
Okay. Laterally.
Laterally, the peritoneum covering the front and back of the uterus meets and extends outwards towards the pelvic side walls as a double sheet. This double fold of peritoneum is the broad ligament.
The broad ligament. We hear that a lot. What does it contain?
Within the layers of the broad ligament run important structures, most notably the ascending uterine artery traveling up along the side of the uterus. The fallopian tube runs in its upper free edge. The ovary is attached to its posterior leaf.
Then ligaments.
Yes, attached to the uterus laterally, particularly at the level of the cervix and extending down onto the lateral vaginal wall, are crucial condensations of that pelvic cellular tissue we talked about. The most important of these is Mackenrod's ligament, also called the cardinal ligament or transverse cervical ligament. This is a major passive support structure for the uterus and upper vagina.
Cardinal ligament. Okay. Now let's revisit that critical anatomical crossing, the uterine artery and the ureter.
This is arguably the most critical relationship to master for anyone doing pelvic surgery. The uterine artery crosses the ureter near the cervix.
How near?
About 1.5 centimeters lateral to the supravaginal cervix at the level of the internal os. Sometimes it's slightly closer on the left side, remember, because of that tendency for uterine dextrotation and cervical levitation.
1.5 centimeter lateral to the cervix, and how do they cross? Which one is on top?
The artery crosses above and in front of the ureter. The classic mnemonic is water, ureter, under the bridge, uterine artery.
Water under the bridge, got it.
This close relationship means that during hysterectomy, when the uterine artery needs to be clamped and cut near the cervix, the ureter lying just underneath and slightly behind is highly susceptible to being accidentally clamped, tied off, ligated, or injured. It's a major cause of surgical complication, if not meticulously identified and protected.
Absolutely critical point. Okay, let's talk uterine structure. 3 layers in the body.
3 layers in the body, yes, from outside in. Perimetrium, myometrium, and endometrium. Perimetrium is just the outer serosal layer. It's the peritoneum covering the uterus.
Myometrium.
Myometrium is the thick middle layer of smooth muscle. This is the bulk of the uterus.
And endometrium.
Endometrium is the inner mucus lining of the uterine cavity. This is the layer that responds to hormones, builds up, and is shed during menstruation if pregnancy doesn't occur.
And a key histological detail here.
Yes, a very key detail. Unlike the gut, there is NO submucous layer in the uterus. The endometrium sits directly on top of the myometrium.
Directly applied. Okay. Now, that myometrium, the muscle layer, you said it's fascinating.
It really is. Outside of pregnancy, the muscle fibers are arranged in complex interwoven bundles. But during pregnancy, 3 distinct layers become much more recognizable. There's an outer longitudinal layer whose fibers run mainly up and down, an inner circular layer with fibers encircling the cavity, particularly prominent around the tube openings and the internal os.
And the middle layer.
And then the middle layer, which is the thickest and most crucial. It's called the interlacing layer or stratum vasculaire. Here, the muscle bundles are densely interwoven in a figure-8 pattern, crisscrossing around the blood vessels that pass through the uterine wall.
Why is that interlacing pattern so important?
It's absolutely critical for hemostasis, stopping bleeding after the placenta separates and is delivered. When the uterus contracts strongly after birth, involution, these interlacing muscle fibers act like living ligatures, physically clamping down on the blood vessels and preventing catastrophic postpartum hemorrhage. Efficient contraction of this layer is literally life-saving.
Wow. Living ligatures. Okay, the endometrium lining, what kind of cells?
The endometrium is lined by a single layer of ciliated columnar epithelium before menopause. It contains simple tubular glands that extend down towards the myometrium.
In the cervix structure, is it mostly muscle too?
No, this is a major difference. The cervix is structurally distinct from the body. It's composed mainly of dense fibrous connective tissue with only about 10 to 15% smooth muscle fibers mixed in. This makes it firm and supportive rather than highly contractile like the body.
Mostly fibrous, and its lining.
The lining also differs. The endocervical canal, the passage through the cervix, is lined by simple columnar epithelium that secretes mucus. The outer surface of the vaginal part of the cervix, the ectocervix, is lined by stratified squamous epithelium, continuous with the vaginal lining.
And the meeting point.
The point where these two types of epithelium meet is called the squamocolumnar junction, SCJ. In younger women, it's usually visible on the ectocervix, but its position changes with age and hormonal status. This junction, this transition zone, is the area most vulnerable to HPV infection and subsequent development of cervical dysplasia and cancer.
The SCJ, critical transition zone.
Okay.
What about secretions, uterine versus cervical?
Chemically very distinct, designed for different roles. Endometrial secretion is typically scanty, thin, and watery. Cervical secretion, on the other hand, produced by the endocervical glands, is alkaline, much thicker, and rich in mucoprotein, fructose, energy for sperm, and sodium chloride.
And its role.
It changes dramatically through the menstrual cycle under hormonal control. Around ovulation, it becomes thin and watery to allow sperm passage. During the luteal phase in pregnancy, it becomes thick and tenacious, forming the cervical mucus plug, which acts as a barrier against infection ascending from the vagina.
Okay. Let's quickly recap the peritoneum relations and the pouches.
Right. So the peritoneum drapes over the uterus. Anteriorly, the reflection from the bladder onto the uterus forms the shallow uterovesical pouch. Posteriorly, the reflection from the back of the uterus and upper vagina onto the rectum forms the much deeper pouch of Douglas. Laterally, the two layers of peritoneum extend outwards as the broad ligament.
And the broad ligament houses the tube and attaches the ovary.
Correct. The fallopian tube runs in its upper free margin. The ovary is attached to the posterior leaf of the broad ligament by a short fold called the mesovarium.
Perfect. Now, neurovascular supply again. Mastery demands knowing the specifics for the uterus. Arterial supply.
Mainly from the uterine artery. This is usually a branch of the anterior division of the internal iliac artery, although sometimes it can arise from the superior vesical artery. It runs medially in the base of the broad ligament, gives off a descending cervicovaginal branch, and then turns upwards to run alongside the uterus within the broad ligament, supplying the body and fundus.
And it connects with other arteries.
Yes, it has important anastomosis connections superiorly with the ovarian artery, coming down from the aorta, and inferiorly with the vaginal artery. This provides a rich collateral supply.
And within the endometrium itself, specific arteries.
Yes, within the uterine wall you have the arcuate arteries, which give rise to radial arteries penetrating the myometrium. These then branch into two types in the endometrium. The basal arteries, which supply the deeper permanent layer, stratum basilis, that isn't shed, and the spiral arteries, which supply the superficial functional layer, stratum functionalis. These spiral arteries are highly sensitive to hormones, constricting before menstruation to cause shedding, and growing extensively during pregnancy to supply the placenta.
Basal and spiral arteries. Crucial distinction. Okay, lymphatics of the uterus. You said highly complex.
Highly complex and absolutely essential knowledge for managing gynecologic cancers. The drainage pathways depend heavily on the specific part of the uterus.
Okay, break it down. Fundus and upper body.
Lymph from the fundus and upper body tends to travel upwards along with the ovarian vessels, draining high up to the preaortic and lateral aortic lymph nodes near the kidneys.
High up. Okay, what about the cornu?
The cornu, that superlateral angle where the tube and ligaments attach, has a unique and clinically important drainage path. Lymphatics from here can travel along the round ligament all the way through the inguinal canal to drain into the superficial inguinal glands in the groin.
Along the round ligament to the groin. That's unexpected.
It is, and it's a crucial exception to remember. Cancers near the cornu can potentially metastasize to superficial nodes you might not expect otherwise.
Good point. Lower body.
Lymph from the lower body generally drains laterally to the external iliac lymph nodes.
And the cervix.
The cervix has the most extensive and variable drainage. It can drain laterally to the external iliac nodes, posterolaterally to the internal iliac and obturator nodes within the pelvis, and posteriorly along the uterosacral ligaments to the sacral nodes. So very broad drainage field from the cervix.
Wow, okay. Fundus upper body to aortic, cornu to inguinal, lower body to external iliac, cervix widely to iliac, obturator, sacral. Got it. Nerves.
Nerve supply involves both sympathetic and parasympathetic systems. The main motor supply, controlling muscle contraction, comes from the sympathetic system, originating around spinal levels T5, T6.
T5, T6 motor. What about sensory?
Pain. Sensory innervation, particularly for pain from the uterine body and fundus, like labor pain, travels back with the sympathetic nerves to spinal cord segments T10 to L1. This is why labor pain is often felt in the lower back and abdomen, corresponding to those dermatomes.
T10, L1, sensory for the body, cervix.
Pain from the cervix and upper vagina travels mainly via the parasympathetic nerves. Back to spinal segments S2, S3, and S4, the pelvic splanchnic nerves. These nerves, synapsing ganglia located near the cervix, collectively called the ganglia Frankenhauser or the uterovaginal plexus.
Okay, different pathways for body versus cervical pain. Now here's a key insight mentioned in the source.
Yes, this is clinically fascinating and somewhat counterintuitive. Despite this complex innervation, the uterus, and especially the cervix, are remarkably insensitive to certain types of stimuli. They are relatively insensitive to handling, incision, like during a C-section or biopsy, or grasping with surgical instruments.
Insensitive to cutting and grabbing.
Largely, yes. While distension of the body causes significant pain, T10, L1, and dilation of the cervix causes pain, S2, S4, direct touch, cutting, or clamping often elicits surprisingly little sensation. This contrasts sharply with the high sensitivity of the peritoneum, the fallopian tubes, the ovaries, and the external genitalia.
That is very interesting. We'll come back to that thought at the end. Okay, continuing our internal inspection, let's look laterally now at the paired fallopian tubes, also known as uterine tubes or oviducts. They're described as about 10 centimeters long.
That's right, roughly 10 centimeters. And they're housed within the upper free margin of that broad ligament we discussed, like a curtain rod holding up the curtain.
They act as a conduit, right, connecting the uterine cavity to the peritoneal cavity.
Exactly. They have two openings. The uterine opening, called the uterine ostium, is tiny, only about 1 millimeter in diameter, and opens into the superolateral angle of the uterine cavity at the cornu.
Okay.
The other end, the pelvic opening, or abdominal ostium, opens directly into the peritoneal cavity near the ovary. This opening is slightly larger, maybe 2 millimeters in diameter.
And that direct opening into the peritoneal cavity is unique.
It is unique in the female anatomy. It provides a pathway for sperm to travel out towards the ovary and for the ovulated egg to travel into the tube. But it also represents a potential pathway for infections to ascend from the lower genital tract, vagina, uterus, and spread into the pelvic cavity, causing pelvic inflammatory disease, PID, and potentially peritonitis.
Ah, right. A direct route for infection. Now, the tube isn't uniform along its length. It's divided into 4 parts.
4 parts, yes. Moving from the uterus laterally outwards, first is the intramural or interstitial part. This is the short segment, about 1.25 centimeters long and very narrow, 1 millimeter diameter, that passes through the actual wall of the uterus at the cornu.
Inside the uterine wall. Okay.
Next is the isthmus. This is a narrow, straight, thicker-walled segment, about 3 to 4 centimeters long, extending laterally from the uterus.
Isthmus, narrow and straight. Third part.
Third is the ampulla. This is the longest part, about 5 centimeters. It's wider, more thin-walled, and tortuous or convoluted compared to the isthmus. The ampulla is the usual site of fertilization.
Ampulla fertilization site. Got it. And the final part.
Finally, the outermost part is the infundibulum. This is the funnel-shaped expansion at the very end of the tube, about 1.25 centimeters long. Its widest diameter can be up to 6 millimeters.
And it has those finger-like projections.
Exactly. The margin of the infundibulum is fringed with about 20 to 25 delicate, finger-like projections called fimbriae. These fimbriae hover over the ovary around the time of ovulation.
Is there a special fimbria?
Yes, one of the fimbriae is typically longer than the others and is directly attached to the outer pole of the ovary. This is called the ovarian fimbria, Fimbria ovarica. Its job is thought to be helping to sweep the ovulated egg into the opening of the fallopian tube.
Clever design. Okay, structurally, what's the tube's lining like? It has to support fertilization and transport, right?
Absolutely. The wall has layers: an outer serous layer, peritoneum from the broad ligament, a muscular layer, outer longitudinal, inner circular smooth muscle for peristalsis, and the intermucous membrane, which is thrown into complex longitudinal folds, especially in the ampulla.
And the epithelium, the actual cells lining it.
The epithelium is crucial for function. It consists mainly of three types of columnar cells. First, ciliated epithelial cells. These make up about 25% of the cells, and they are most predominant out near the ovarian end in the ampulla and infundibulum. Their cilia beat rhythmically towards the uterus, creating a fluid current that helps transport the egg or zygote along.
Okay, cilia for transport. Second type.
Second are secretory columnar cells. These are the most abundant, about 60%, especially in the narrower isthmic segment. They secrete fluids that provide nourishment for the egg, sperm, and the developing embryo during its journey to the uterus.
Secretory cells for nourishment. And the third type.
Third are PEG cells, or intercalary cells. These are less common, possibly non-ciliated variants of the secretory cells, maybe representing an exhausted phase. Their exact function is less clear.
So cilia, secretory cells, PEG cells, a dynamic lining.
It's very dynamic. The proportions and activity of these cells change throughout the menstrual cycle under hormonal influence, optimizing the environment for potential fertilization and early embryo transport.
And the function overall is this exquisitely balanced coordination.
Exactly. It's coordinating that ciliary action, the muscular contractions, peristalsis, and the secretions to successfully transport the sperm outwards, capture the egg, facilitate fertilization in the ampulla, and then carefully transport the developing zygote back to the uterus over several days, timing its arrival perfectly for implantation.
Amazing timing. Blood supply and nerves for the tube.
Blood supply comes from both ends, reflecting its dual origin. It gets branches from the uterine artery medially and from the ovarian artery laterally, these anastomos along the tube. Drainage is via veins that follow the arteries, joining the uterine plexus and the ovarian pampiniform plexus.
Okay. Nerves. Sensitivity.
Nerve supply comes from both the ovarian and uterine plexuses. Now here's a sharp contrast to the uterus. The fallopian tube is highly sensitive to handling. Yes. Manipulation, clamping, or even palpation during surgery can elicit significant pain. This is a key point to remember when considering surgical approaches or diagnosing pelvic pain. Much more sensitive than the uterus itself.
Good contrast. Okay, let's move to the ovaries. Hashtag tag 3.2 ovary. Gonads. Right, the ovaries. The primary paired female gonads, described as oval-shaped, sort of pinkish gray, and often having a scarred or pitted surface in women during their reproductive years.
That scarred appearance is from repeated ovulations over time. Each time a follicle ruptures to release an egg, it leaves a tiny scar.
And their function is twofold.
Exactly. Two key roles. First, maturation and release of germ cells of the eggs, or ova, through the process of ovulation. Second, steroidogenesis, the production of the primary female sex hormones, estrogen and progesterone, as well as smaller amounts of androgens.
Now, positionally, they are considered intraperitoneal structures.
Yes, they lie within the peritoneal cavity. However, there's a nuance. Unlike most other intraperitoneal organs, like the uterus and tubes, which are covered by peritoneum, the surface of the ovary itself is generally not covered by peritoneum.
Oh, what covers it then?
It's covered by a single layer of specialized cubicle cells called the germinal epithelium. This was once thought to be the origin of the eggs, hence the name, but we now know the germ cells migrate into the ovary during embryonic development. Still, that germinal epithelium covering is distinct from the surrounding peritoneum.
Okay, germinal epithelium, not peritoneum. Where exactly does the ovary sit in the pelvis?
In a woman who hasn't given birth, a nullipara, the ovary typically lies in a specific shallow depression on the lateral pelvic wall called the ovarian fossa, or fossa of Waldeyer.
And where is this fossa located?
It's bounded by some major structures. Typically, the external iliac vessels are anterior superior to it, and the internal iliac vessels and the ureter are posterior inferior to it.
Okay, nestled amongst major vessels and the ureter, what holds the ovary in place? Its attachments.
It has several key attachments or ligaments. First, it's attached to the posterior leaf of the broad ligament by that short fold we mentioned, the mesovarium. This is how blood vessels and nerves enter the ovary at its hilum.
Mesovarium.
Second, it's connected to the lateral angle, cornu, of the uterus by the ovarian ligament, or utero-ovarian ligament, a fibrous cord containing some smooth muscle.
Ovarian ligament to the uterus.
Third, its upper tubal pole is attached to the lateral pelvic wall by the infundibulopelvic ligament, also called the suspensory ligament of the ovary. This isn't a true ligament like the ovarian ligament. It's actually a fold of peritoneum that contains the main ovarian artery and vein as they travel down from the abdominal aorta vena cava.
Infundibulopelvic ligament contains the vessels. Got it. Let's focus on the relations of that ovarian fossa again. Vital for deep pelvic surgery.
Absolutely vital. So superiorly to the ovary and the fossa, you typically find the external iliac vein. Posteriorly, running behind the ovary, are the ureter and the internal iliac artery and vein. Laterally, the ovary is separated from the obturator nerve and vessels, which run on the pelvic side wall, by the parietal peritoneum lining the fossa.
So the ureter runs directly behind the ovary, another high-risk relationship.
Exactly. Injury to the ureter during ovarian surgery, like removing an ovarian cyst or the whole ovary, is a significant risk because of this close posterior relationship.
Okay. Let's look inside the ovary now, cortex and medulla.
Yes. The substance of the ovary is divided into an outer cortex and an inner medulla.
What's in the cortex?
The cortex is the main functional part during the reproductive years. It lies just beneath that germinal epithelium and a dense connective tissue layer called the tunica albuginea. The cortex contains the ovarian follicles in all stages of development. Primordial follicles, the resting pool, maturing follicles, primary, secondary, the large, fluid-filled Graafian follicle ready for ovulation, and the temporary endocrine structure formed after ovulation, the corpus luteum.
And after the corpus luteum degenerates.
If pregnancy doesn't occur, the corpus luteum shrinks and becomes scar tissue, called the corpus albicans. The accumulation of these corpora albicantia contributes to that scarred appearance of the adult ovary. Also, the process of follicular atresia, where follicles start developing but then fail and degenerate, also happens constantly in the cortex.
Okay, cortex is the business end with follicles and corpora lutea. What's in the medulla?
The medulla is the central core of the ovary. It consists of looser connective tissue, and importantly, it contains the main blood vessels, lymphatic vessels, and nerves that enter the ovary through the hilum via the mesovarium.
Any special cells in the medulla?
Yes. Scattered within the medulla, particularly near the hilum, are clusters of cells called hilus cells.
Homology time.
Homology time. These hilus cells are homologous to the interstitial cells of Leydig in the testes. Like Leydig cells, they can produce androgens, although normally in very small amounts in females. Certain ovarian tumors arising from these cells can cause virilization due to excess androgen production.
Hilus cells, epithelial Leydig cells. Got it. Now, blood supply to the ovary. You mentioned it's unique.
Yes, this is high-level knowledge, different from the other pelvic organs. The primary arterial supply, the ovarian artery, doesn't arise from the internal iliac artery within the pelvis. It arises much higher up, as a direct branch of the abdominal aorta, usually just below the renal arteries.
Comes straight off the aorta.
Correct. It then travels down retroperitoneally, crosses the external iliac vessels, and enters the pelvis within that infundibulopelvic ligament to reach the ovary via the mesovarium. It anastomoses with the ovarian branch of the uterine artery.
Okay, direct aortic branch. What about venous drainage? Is it symmetrical?
No, it's asymmetrical, and this is clinically important. Venous blood drains out through a network of veins in the mesovarium called the pampiniform plexus, similar to the one in the male spermatocord. This plexus then coalesces to form the main ovarian vein.
And where do the ovarian veins drain?
Here's the asymmetry. The right ovarian vein drains directly into the inferior vena cava at an oblique angle. However, the left ovarian vein typically drains into the left renal vein at a right angle.
Left into left renal, right into IVC. Why does that matter?
That drainage into the left renal vein, often at a higher pressure and less direct angle, might contribute to the fact that varicosities, varicocele though less common than in males, and venous thrombosis, like ovarian vein thrombophlebitis, especially postpartum, are more common on the left side.
Interesting anatomical explanation for a clinical difference. Nerve supply.
Nerve supply is primarily sympathetic, traveling down as a plexus along with the ovarian artery from the aortic plexus. The sensory fibers conveying pain from the ovary travel back with these sympathetic nerves to the spinal cord at the T10 segment.
T10. So ovarian pain is referred where?
Often referred to the T10 dermatome, which is around the level of the umbilicus in the mid-abdomen, sometimes confused with appendicitis if it's on the right.
And sensitivity, like the tube.
Yes, like the fallopian tube, the ovaries are quite sensitive to manual squeezing or pressure, which can elicit significant pain. Again, different from the relative insensitivity of the uterus itself.
Good distinction. Okay, that covers the internal organs themselves. Now let's move to the critical supporting framework.
Exactly. We shift focus now from the organs themselves to the architectural foundation that holds everything up. Without this strong dynamic support system, the whole thing fails, leading to problems like prolapse.
And the main component of this support is the pelvic floor.
Yes, the main muscular support is provided by the levator antemuscle complex. This broad sheet of muscle forms the major part of the pelvic floor, often called the pelvic diaphragm.
And what does it separate?
Functionally, it forms a muscular partition that separates the pelvic cavity above from the anatomical perineum below.
Okay, mastery requires knowing the components of the levator ani. It's not just one muscle.
Not just one. It's typically described as consisting of three main sets of paired muscle fibers, although the divisions can be somewhat complex and debated. The main components are the pubococcygeus, the iliococcygeus, and the ischiococcygeus, sometimes called coccygeus, and considered separate by some, but functionally part the posterior floor.
Pubo, ilio, and ischiococcygeus.
The entire muscular diaphragm formed by these muscles is covered on its superior pelvic surface by a layer of fascia called the parietal layer of pelvic fascia, and on its inferior perineal surface by the anal fascia.
And functionally, the levator ani isn't a complete sheet, is it? It has gaps.
Correct. It doesn't form a solid floor. It forms more of a muscular sling or hammock that's open in the middle. It has two significant gaps or hiatuses. The large anterior gap is the hiatus urogenitalis. This allows passage for the urethra and the vagina. This gap is functionally closed or supported inferiorly by the structures of the urogenital triangle, specifically the perineal membrane and muscles.
Okay, hiatus urogenitalis for urethra and vagina, the posterior gap.
The smaller posterior gap is the hiatus rectalis, which transmits the terminal part of the rectum as it becomes the anal canal.
Now, why does the levator ani truly matter? Its functions are critical for pelvic health, right?
Absolutely critical. Let's break down its key functions. First, and perhaps most importantly, support. Specific parts of the levator ani, particularly the medial fibers of the pubococcygeus, known as the pubovaginalis in females, and puborectalis, form a crucial U-shaped sling that passes behind the vagina and rectum.
A U-shaped sling.
Yes. This sling actively supports the vagina, which in turn acts as a platform supporting the bladder anteriorly and the uterus superiorly. Weakness, stretching, tearing, or even complete detachment, avulsion of this pubovaginalis sling from the pubic bone, often due to childbirth injury, is the primary mechanical cause of pelvic organ prolapse, where the bladder, uterus, or rectum can bulge down into the vagina.
So prolapse is fundamentally a levator ani problem.
Yeah.
Second function.
Second, pressure maintenance. The pelvic floor constantly works with the abdominal muscles and diaphragm to maintain and regulate intra-abdominal pressure. This is critical for functions like coughing, sneezing, vomiting, lifting heavy objects, and even forced expiration. A strong pelvic floor helps prevent urinary leakage during these pressure events.
Okay, third function related to childbirth.
Third, parturition. The pelvic floor plays a crucial role during labor and delivery. The sloping shape of the levator ani helps guide the baby's head downwards and forwards, facilitating the normal anterior internal rotation of the presenting part as it descends through the pelvis.
Guides the rotation. What else?
Then, during the second stage of labor, as the baby crowns, the pubovaginalis and puborectalis components must undergo a crucial, coordinated relaxation and stretching to allow the baby's head to pass through the hiatus urogenitalis without causing excessive damage.
What happens if it doesn't relax properly?
Failure of the levator ani to relax appropriately at this critical moment can lead to a prolonged second stage, increased risk of maternal exhaustion, and importantly, can result in extensive, sometimes permanent, tearing or overstretching damage to the muscle itself, predisposing the woman to prolapse and incontinence later in life.
Wow. So support, pressure, and guiding relaxing in childbirth. Very important muscle. Okay, let's define the perineum more precisely.
Right. Anatomically speaking, the perineum is the diamond-shaped area at the outlet of the pelvis. It's bounded by the bones of the pelvic outlet, the pubic symphysis anteriorly, the ischial tuberosities laterally, and the coccyx posteriorly.
And it's divided.
Yes. An imaginary line drawn between the two ischial tuberosities divides this diamond into two triangles. The anterior triangle is the urogenital triangle. This contains the external genitalia, which we've already discussed, and the structures associated with the urethra and vagina. This triangle has major obstetric importance because it's the area most affected by childbirth and episiotomy. The posterior triangle is the anal triangle. This contains the anal canal, the external anal sphincter, and the ischioanal or ischiorectal fossae filled with fat. This triangle generally has less direct obstetric importance, though the sphincter can be involved in severe tears.
Okay. Urogenital triangle, anterior obstetric focus, and anal triangle, posterior. Let's look closer at the urogenital triangle. It has layers or pouches.
Yes, the urogenital triangle is structured into two important fascial spaces or pouches lying superficial to the pelvic diaphragm, levator ani. The more superficial space is the superficial perineal pouch. This lies between the skin subcutaneous fascia, callus fascia, and the perineal membrane, the inferior fascia of the urogenital diaphragm.
What's in the superficial pouch?
It contains the erectile tissues, clitoral crura, vestibular bulbs, the muscles covering them, ischiocavernosus, bulbospongiosus, the superficial transverse perineum muscles, and Bartholin's glands.
Okay. And the deeper pouch?
Deep to the perineal membrane is the deep perineal pouch. This is a more enclosed space, essentially formed by the urogenital diaphragm itself.
And what's in the deep pouch?
It contains the deep transverse perineum muscles, and importantly, the external urethral sphincter complex, often called the sphincter urethrae membranacea, which surrounds the middle part of the urethra. Some associated glands and neurovascular structures are also found here.
Okay, superficial and deep pouches in the UGO triangle. Now, from an obstetrical viewpoint, the real focus is the perineal body.
Absolutely.
Right.
The obstetrical perineum, or more accurately, the perineal body or central tendon of the perineum, is the anatomical nexus, the central point of this whole region.
Describe it.
It's a pyramidal-shaped mass of fibromuscular tissue, roughly 4 centimeters by 4 centimeters in dimension, located in the midline between the posterior limit of the vaginal opening, the fourchette, and the anterior aspect of the anal canal.
4 by 4 centimeter mass between vagina and anus. What meets there? Why is it so important?
It's the critical convergence point where many of the pelvic floor and perineal muscles and fasciae meet and interdigitate, providing mutual support. It integrates several fasciae, including collocyca superficially and layers of the urogenital diaphragm more deeply, and multiple muscles. The superficial and deep transverse perineum muscles insert into it laterally. The bulbospongiosus muscle anchors to it anteriorly. A few fibers of the external anal sphincter blend into it posteriorly. And most importantly, the anterior fibers of the pubococcygous part of the levator ani attach into its superior aspect.
So it's like a central anchoring point for the whole system.
Exactly. It acts like a central tendon. By anchoring these muscles, it directly supports the integrity of the levator ani sling, especially its anterior portion. And by supporting the posterior vaginal wall, it indirectly helps maintain the position of the bladder anteriorly and the uterus superiorly.
Its importance really can't be overstated then.
Cannot be overstated. Because it's this concentration point of support, and because it's located right in the path of the descending fetal head, it is highly vulnerable to injury during childbirth, both stretching and tearing. This is precisely why it's the standard site for performing a surgical incision, an episiotomy, if needed, to theoretically control the direction and extent of tearing, although the routine use of episiotomy is now debated.
Right. Okay, one more supporting element. The pelvic cellular tissue and fascia.
Yes, beyond the muscles, there's this crucial network of connective tissue. The pelvic fascia is broadly divided into parietal fascia, lining the muscular walls of the pelvis, generally tough and membranous, and visceral fascia, covering the pelvic organs, typically looser and more areolar.
And the space between.
The space between the peritoneum lining the pelvic cavity superiorly and the pelvic floor muscles inferiorly and surrounding the pelvic organs is filled with pelvic cellular tissue. This is basically loose connective tissue containing varying amounts of fat, blood vessels, lymphatic channels, and nerves.
And this tissue has a specific name around the cervix.
Yes, the pelvic cellular tissue that specifically surrounds the vaginal vault and the supravaginal part of the cervix and extends laterally between the layers of the broad ligament is clinically termed the perimetrium.
Perimetrium, okay. And condensations of this tissue form ligaments.
Exactly. While much of it is loose, condensations or thickenings of this visceral pelvic fascia and cellular tissue form the major passive supporting ligaments of the uterus and vagina. We already mentioned the most important one laterally, Mackenrod's ligaments, the cardinal ligaments.
What others?
Posteriorly, there are the uterosacral ligaments running from the cervix back towards the sacrum. Anteriorly, there are the vesicocervical ligaments, or pubocervical fascial ligaments, connecting the cervix to the bladder and pubis. These fascial ligaments, along with the levator ani muscles, are the key elements holding the uterus and vagina in place.
Okay, now this cellular tissue, it's protective but also poses a risk.
Yes, this raises an important clinical question for mastery. While this tissue forms protective sheaths around the blood vessels and the ureter as they traverse the pelvis, it also acts as a potential superhighway for the spread of pathological processes, particularly infection.
How so?
Pelvic cellulitis infection within this perimetrial tissue, often originating from the uterus or cervix, like after childbirth or surgery, can spread relatively easily along these loose connective tissue planes.
Spread where?
We must know the potential routes of spread, as this dictates where complications might arise. Infection can track, superiorly along the course of the ureter, potentially reaching the perinephric space around the kidney. Posterolaterally along the gluteal vessels, exiting the pelvis through the sciatic foramina and presenting as an abscess in the buttock. Anterolaterally along the external iliac vessels under the inguinal ligament, potentially reaching the thigh. Anteriorly along the round ligament through the inguinal canal, potentially reaching the groin or labia majora.
Wow. So infection can travel quite far along these tracts?
It can. Knowing these potential avenues of spread is absolutely vital for diagnosing and managing complex pelvic infections and their complications.
Okay, we conclude our deep dive now by examining the essential associated organs that sit within or relate closely to the reproductive system. Let's start with the urinary system components found in the pelvis. The female urethra first.
Right, the female urethra. It's relatively short compared to the male, measuring only about 4 centimeters in length, with a diameter of about 6 millimeters.
And its course.
It extends downwards and slightly forwards from the bladder neck, internal urethral meatus, passing behind the pubic symphysis to open at the external urethral meatus in the vestibule, about 2.5 centimeters below the clitoris, as we located earlier.
Okay. And its relationship to the vagina.
Crucial relationship. As we mentioned when discussing the vagina, the upper half of the urethra is separated from the anterior vaginal wall by some loose connective tissue. But the lower half is firmly embedded within the anterior vaginal wall. They are structurally fused in that lower segment.
Firmly embedded. Why is that clinically relevant?
It means that significant trauma to the anterior vaginal wall during childbirth, or surgical procedures involving the anterior vaginal wall, like prolapse repairs, can potentially compromise the integrity or function of the urethra, leading to issues like incontinence or fistula formation.
Okay. And it's surrounded by a sphincter?
Yes, in its middle third, as it passes through the deep perineal pouch, urogenital diaphragm, it is surrounded by the external urethral sphincter complex, the sphincter urethrae membranaceae, which provides voluntary control over urination.
What about glands within the urethra? Skene's glands.
Exactly. The urethral lining contains numerous small mucus-secreting periurethral glands. The largest and most clinically significant of these are the two Skene's ducts, which open just inside or beside the external urethral meatus.
And we reiterate the homology.
Skene's glands are the female equivalent of the prostate in the male. And just like the prostate, they can be prone to chronic infection, skenitis, or less commonly, adenoma formation.
Okay. Moving up to the urinary bladder.
The urinary bladder, the hollow muscular reservoir for urine. Its normal functional capacity is around 400 to 500 milliliters, but it's incredibly distensible due to its muscular walls, the detrusor muscle, and folded lining, rugae. It can potentially hold up to 3 or 4 liters in cases of chronic retention, though obviously that's pathological.
Wow. Any specific internal landmarks? The trigone?
Yes, the trigone is a key internal landmark. It's a smooth, triangular area on the inner surface of the bladder base. Its 3 corners are marked by the openings of the 2 ureters entering posterosuperiorly and the single opening of the urethra antero-inferiorly, the internal meatus. This trigonal area is developmentally distinct from the rest of the bladder and is particularly sensitive to stretch.
Okay. Nerve supply for the bladder. Critical for continence.
Very critical for understanding bladder function and dysfunction. It has both autonomic, sympathetic and parasympathetic, and somatic innervation. The parasympathetic supply comes from spinal segments S2, S3, S4 via the pelvic splanchnic nerves, nervia eugenicus. This is the nerve of evacuation. Parasympathetic stimulation causes contraction of the powerful detrusor muscle in the bladder wall and relaxation of the internal urethral sphincter at the bladder neck, leading to urination.
Parasympathetic evacuation. Sympathetic.
The sympathetic supply comes from the thoracolumbar region, TL and L2. It generally has the opposite effect, relaxing the detrusor muscle, allowing filling, and contracting the internal sphincter, maintaining continence. Importantly, the sympathetic nerves also convey the painful stimuli associated with excessive bladder overdistension.
Okay. And somatic for the external sphincter.
Yes, the external urethral sphincter, sphincter urethrae membranaceae, is under voluntary control via the pudendal nerve, S2, S3, S4.
Got it. Now, the pelvic ureter, the part of the ureter within the pelvis.
Right, the pelvic ureter. After crossing the pelvic brim, the ureter runs down the pelvic side wall for about 13 centimeters before reaching the bladder. It's entirely retroperitoneal throughout its course.
And its relations.
It enters the pelvis, typically crossing over the bifurcation of the common iliac artery, or the beginning of the external iliac artery near the sacroiliac joint. It then runs downwards, lying anterior to the internal iliac artery and posterior to the ovary. Remember that ovarian-fossa relationship?
Okay, behind the ovary, in front of the internal iliac artery.
Then, as it reaches the pelvic floor, it curves forwards and medially, passing through the base of the broad ligament within that pelvic cellular tissue, perimetrium.
And this is where the critical crossing happens again.
This is exactly where the critical crossing happens. As the ureter courses forwards and medially through the base of the broad ligament, it is crossed anteriorly from above and in front by the uterine artery.
Water under the bridge again.
Water under the bridge again. And we reiterate the distance. This crossing typically occurs about 1.5 centimeters lateral to the supravaginal part of the cervix. The ureter then continues forward to pierce the base of the bladder wall obliquely.
That oblique entry into the bladder is important too, right?
Yes, that oblique passage through the bladder wall acts like a valve, preventing urine from refluxing back up the ureter when the bladder contracts and pressure rises.
Makes sense. Are there points where the ureter naturally narrows?
Yes, clinically important. There are 3 key points of physiological constriction along the ureter's pelvic course where kidney stones, ureter calculi, are most likely to become lodged. 1, where it crosses the pelvic brim and the iliac vessels. 2, where it is crossed by the uterine artery in the base of the broad ligament. 3, where it passes through the bladder wall, the intravesical or intramural part.
Pelvic brim, uterine artery crossing, bladder wall entry. Good to know for stone locations. Okay, that covers the urinary organs. Let's finish with the accessory reproductive organs, the breasts. Hashtag tagged 5.2 breasts, accessory reproductive organs.
Right, the breasts or mammary glands. Technically, they are highly modified sebaceous glands, oil glands of the skin. They're specialized for lactation, the production of milk after childbirth.
And their typical location or extent on the chest wall?
In the adult female, the base of the breast typically extends vertically from the level of the 2nd rib down to the 6th rib, and horizontally from the edge of the sternum medially toward the mid-axillary line laterally. A portion often extends towards the armpit, called the axillary tail of Spence.
2nd to 6th rib. Okay. What's the composition? Is it mostly gland?
Interestingly, no. In the mature non-lactating state, the breast composition is highly relevant, especially for imaging like mammography. It's composed of only about 20% functional glandular tissue, lobules and ducts. The vast majority, around 80%, is made up of fat, interspersed with supportive connective tissue.
Only 20% gland, 80% fat in the non-lactating state. Good ratio to remember. What about the key external structures, areola and nipple?
Yes. The nipple is the conical projection at the center, containing the openings of the lactiferous ducts. It's composed of smooth muscle fibers that allow it to become erect in response to stimuli. Surrounding the nipple is the pigmented circular area called the areola.
What's special about the areola?
The areola contains small, scattered sebaceous glands called Montgomery glands, or tubercles. These become more prominent during pregnancy and secrete an oily substance that lubricates and protects the nipple and areola. They may even secrete small amounts of milk.
Okay. Inside the breast, the duct system.
Internally, the glandular tissue is organized into about 15 to 20 lobes, each lobe draining via its own lactiferous duct towards the nipple. Just before reaching the nipple surface, each lactiferous duct dilates slightly to form a small reservoir called the lactiferous sinus.
Lactiferous sinus, what's its function?
The sinus, located maybe 5 to 10 millimeters back from the duct opening, is thought to act as a small storage reservoir where milk can accumulate just before being ejected during suckling or pumping.
Okay. What provides structural support within the breast?
Structural support, maintaining the shape and contour of the breast against gravity, is provided primarily by fibrous connective tissue septa called Cooper's ligaments or suspensory ligaments. These extend from the deep fascia overlying the pectoral muscles outwards through the breast tissue to attach to the dermis of the skin.
Cooper's ligaments, and they're clinically relevant.
Very relevant in breast cancer. If a tumor invades and contracts these ligaments, it can pull on the overlying skin, causing the characteristic sign of skin dimpling or tethering.
Ah, right. Microscopically, where is milk actually made and ejected?
Milk secretion occurs within the terminal functional units of the glands, the alveoli, or acini, which are clustered together in lobules. These alveoli are lined by milk-secreting columnar epithelial cells.
Okay, epithelial cells make the milk. How does it get out?
Milk ejection, the letdown reflex, is an active process controlled by specialized cells called myoepithelial cells. These are star-shaped, contractile cells that actually have features of both epithelium and smooth muscle. They contain actin and myosin. They form a basket-like network surrounding the alveoli and the smaller ducts.
Myoepithelial cells squeeze the milk out.
Exactly. When stimulated by the hormone oxytocin, released in response to suckling, these myoepithelial cells contract forcefully, squeezing the milk out of the alveoli, into the ducts, through the sinuses, and out of the nipple.
Oxytocin triggers myoepithelial contraction for letdown.
Got it. Now, breast tissue is known to be very sensitive to hormones. How does it change with the ovarian cycle? Exquisitely sensitive. The glandular tissue undergoes cyclical changes throughout the menstrual cycle, driven by estrogen and progesterone. During the follicular phase, first half of the cycle, when estrogen levels are rising, there is primarily proliferation and growth of the ductal system.
Estrogen ducts grow. Luteal phase.
During the luteal phase, second half after ovulation, rising progesterone levels, along with continued estrogen, cause dilatation of the ductal system, and importantly, differentiation and development of the alveolar cells within the lobules, preparing them for potential milk production. This luteal phase activity, with increased glandular tissue and fluid retention, is often what causes the common premenstrual symptoms of breast tenderness, fullness, or swelling.
Progesterone alveoli develop, causing fullness. Makes sense. And after menopause.
Postmenopausally, with a decline in estrogen and progesterone production, the lobules and ducts undergo gradual atrophy or involution. The glandular tissue largely regresses and is replaced by more fatty tissue.
Okay. What about developmental anomalies? Accessory breasts.
Yes, anomalies can occur. Accessory breasts, polymastia, or more commonly just accessory nipples, polythelia, can develop anywhere along the embryonic milk line, which runs from the axilla down to the groin on both sides.
Supernumerary nipples, polythelia, is that clinically significant?
The presence of supernumerary nipples, polythelia, is clinically significant because studies have shown it's associated with roughly a 10% incidence of underlying renal kidney abnormalities. So finding an accessory nipple should prompt consideration of screening for kidney problems.
10% renal association with polythelia, good clinical link. Finally, lymphatic drainage of the breast, critically important for breast cancer staging and treatment.
Absolutely critical and quite complex. The vast majority, around 75% of lymphatic drainage from the breast, particularly from the lateral hemisphere, outer half, goes to the axillary lymph nodes in the armpit, specifically the anterior pectoral group first.
75% to axilla. Where else?
Lymph from the upper part of the breast, upper convexity, can drain upwards toward the infraclavicular group of nodes located just below the clavicle.
Okay, medial part.
Lymph from the medial convexity, inner half of the breast, has a different primary route. It tends to drain medially, piercing the intercostal spaces, to reach the internal mammary chain of lymph nodes, which run alongside the sternum inside the chest wall.
Internal mammary chain for the medial breast? Is there connection between the two breast lymphatics?
That's a key surgical detail. While there are some potential cross-connections, significant lymphatic flow from one breast to the contralateral opposite side typically only occurs if the primary ipsilateral pathways, axillary and internal mammary, are blocked or obstructed, for example, by extensive tumor involvement or previous surgery radiation. Normally, drainage stays on the same side.
Okay, mainly ipsilateral unless blocked. That detailed mapping is essential. Hashtag tag outro. So let's try to synthesize this. What does this incredible journey through the female pelvis mean? I feel like we've achieved a much deeper understanding, really aiming for that mastery of the female reproductive system and its entire supporting architecture.
I think so. We've moved layer by layer, haven't we? From the, heavily vascularized external genitalia and the really specific homologies to male structures.
Right, those homologies were fascinating.
Through the intricate three-dimensional relations of the vagina and uterus, those critical crossings.
Water under the bridge.
Exactly. And finishing up with the hormonal responsiveness, the dual blood supplies, the complexity of the associated urinary organs, and the accessory organs like the breasts.
For me, the key takeaway has to be the absolute reliance of the entire system, all those visceral organs on the supporting framework.
Couldn't agree more. It's the often overlooked parts. The pelvic fascia, that cellular tissue which acts as a pathway for good and bad.
The superhighway of spread, yeah.
And especially the levator antemuscle sling and that central anchor point, the perineal body. These structures aren't just passive supports. They form this dynamic muscular hammock. It dictates organ position, prevents prolapse, and, as we saw, represents perhaps the single greatest vulnerability of the system during the trauma of childbirth.
Yeah, that connection between levator injury and prolapse was really clear. Now, throughout this deep dive, we kept noting a contrast in sensitivity.
We did.
The fallopian tube and the ovary are highly sensitive to handling, to squeezing. But the uterus and the cervix, the absolute core organs of gestation and birth, were described as profoundly insensitive to things like incision and manipulation.
That's a striking difference.
So here's the final provocative thought for you, our listeners, to mull over. Given that the system relies elsewhere on precise pain signaling, T10L1 for uterine body distension, T10 for the ovary, the intense sensitivity of the external genitalia, what could be the evolutionary advantage to the deep internal reproductive organs, the uterus and cervix, being so dramatically quiet in the face of direct visible trauma like cutting or clamping.
What does this functional insensitivity suggest about the body's priorities? Is it perhaps prioritizing a pathway to function, allowing procedures or even childbirth itself to proceed without triggering catastrophic pain reflexes? Or is it somehow protecting itself from those potentially debilitating reflexes? Is the lack of sharp pain signaling in those specific tissues actually protective in some way?
Something for you to mull over, or perhaps explore further on your own. It certainly highlights the incredible and sometimes perplexing design of the system.